Section 1115 of the Social Security also reported that several state programs approved for federal Medicaid funds a process in which CMS often approves a demonstration for one size, a similar demo for CMS has a responsibility to Medicaid patients and taxpayers to be transparent with their criteria for disapproving state demonstrations, and yet they have for a committee of jurisdiction to explain their process. The agencies.
The state of Indiana recently received a 1115 waiver. It was a very successful program implemented under former Governor Mitch Daniels. And rather than expand traditional Medicaid, Governor Pence created HIP 2.0 to cover our state's most vulnerable population, but not require that they go on traditional Medicaid. 83,000 at this point enrolled in the program, and actually 71% of those opt to pay in and pay more to get dental and vision. This program is already working. I look forward to it can continue HIP 2.0 when this waiver expires.
Recognize the ranking member of the subcommittee. 5 minutes for opening statement.
I'd like to thank the chair for having this and look forward to today's discussion. It provides health care coverage for more than 70 million Americans. It's our nation's most health care safety net program. Today it covers more than 1 in 3 children and is a critical component of care. Waiver is different in scope and focus. We'll hear from GAO about its body of work.
72 million people being covered by the program. We need a better understanding about how the billions of dollars CMS is approving promote Medicaid. It is essential that CMS is transparent and certainly predictable. Recent analysis and media coverage has raised questions. CMS is effectively picking in the waiver review process. CMS has a duty both to patients and taxpayers, to states, all stakeholders to do.
Been here before, and one of the has been the number one factor. Negotiations. It has been publicly noticed that even though the Supreme Court has ruled that the administration may not coerce into expanding its Medicaid under the ACA, that may be in fact what is happening when the state comes to talk about an 1115 waiver. In April, the Center for Medicaid Services explicit funding for Florida's low-income pool to Medicaid that it would cost the state as much as $27 billion. Mr. Chairman, I'm grateful for holding the hearing today and look forward to the testimony of our witnesses and their answering our questions. I'll yield back.
Chair, thanks, gentlemen. Has sent me a message. He said he would be late.
And Ranking Member Green, and thank you for calling this important hearing. We can all agree we still have more to do, so I'll look forward to your testimony today on how we can continue to work to make these demonstration projects and waivers. They don't allow people to get primary and preventative care, and they don't from financial harm resulting from to your citizens. After being on notice since 2011, Florida got extension of the LIP. 30th, 2015, Republican-led state Senate wanted a coverage model. So they went into a budget impasse. And fortunately, they have resolved it. Unfortunately, they did not adopt a coverage model. And we're on notice that they are going to yield back my time.
Chair, thanks the gentlelady. That concludes the opening statements. As usual, and on our we have Ms. on that, yeah.
Pitts, Ranking Member Green, and members of the subcommittee. I'm here to discuss GAO's work on Medicaid demonstration spending. Demonstrations comprise a significant and fast. Based on this work, we have concerns with HHS approvals. First, transparency. HHS's bases for approvals of new costs not otherwise eligible for limits that could potentially increase federal Medicaid costs by tens of billions of dollars. I'll turn now to our report findings. In April, we reported that HHS has approved states to obtain federal Medicaid funds for a broad range of 2 prominent types of new costs not otherwise eligible were approved. The first was for state-operated programs. HHS states to spend up to $9.5 billion for more than 150 state-operated programs, $8 billion for incentive providers to improve delivery and infrastructure. Again, approval documents were not always clear regarding how the spending would further objectives and not duplicate other federal funding streams. To our work on budget neutrality, which to the extent HHS has ensured most states to use questionable assumptions to project how much their Medicaid program would cost without the demonstration. Such assumptions, once approved, become the basis of spending allowed under the demonstration. In our reports in 2013, we estimated that HHS includes my statement. I'm happy to answer any questions.
Chair, thanks to minutes for that purpose. Ms. Iritani, in your testimony, you indicated that CMS has 4 criteria. Again, these criteria are not even. Oh, did CMS create them out of thin air? Where'd they come from?
We for CMS's criteria during the course of our review, and that criteria were not provided until they reviewed a copy of the report.
Now, you raised concerns that the criteria CMS enumerated for its review programs are
Medicaid documentation that we reviewed regarding the approvals, clear as to how they made their decisions about what to approve. The statute is quite broad with regard to the Secretary's authority approving. Well, we believe that
the worries that I and many of my have is that
I would agree that Medicaid funds should be Medicaid purposes. And the approval documentation that we reviewed for not approved spending is furthering Medicaid purposes.
Thank you again for your testimony. We hear a lot of criticism of the lack of flexibility of CMS for waivers, but what I heard and seen with uncompensated care pools. Is that correct?
That's correct.
In reviewing the GAO's recommendations over the last 20 years, it appears as though recommendations have remained the same until only recently. Isn't it true that the majority of these recommendations are not acted upon up until the Obama administration?
We would say that there's more need for transparency, for criteria around how they make their decisions, around better methods allowed for predicting how much the Medicaid program would cost without the demonstration, which becomes
Potential there for federal match?
Yes, that's correct. I think with the approval documentation around duplication was that there was variation in the level of protections in the approval document.
Chair, thanks, gentlemen. I recognize the gentleman from Illinois, Mr. Shimkus. 5 minutes for questions.
Thank you very much, Mr. Ms. Iritani. It's great to have you. And I've been focused on this budget waiver neutrality debate. 2015 that says at least at the facts of dollars, the claims not being substantiated by the fact of bill.
At the budget neutrality of one state's approval, we did note that the actuary was asked to review the state's proposal, including the proposed spending limits and the basis for it, and had raised questions with it, but was and asked for further documentation that was not provided by the state. And the spending limit was approved, and we found that it was likely going to raise federal costs.
So, you know, that story kind of just supports our concern and the reason why we dropped the bill. And it's very short, but what we require then is a certification process by the actuaries, which would then, I think, empower them to make sure they get all the information they need to be able to to certify based upon the best available information that this is going to be budget neutral, or in essence an implied savings. So I appreciate you being here. It's a tough issue. Money is always what you fight about. So thanks for coming. I yield back my time.
Chair, thanks, gentlemen. Now I recognize the gentlelady from California, Ms. Capps. 5 minutes for questions.
Thank you, Mr. Chairman. for holding this hearing and to our witness for your testimony. I'm happy we have this opportunity to come together to talk about these important Medicaid waivers, something that's really truly helped my state respond creatively to its challenges and provide health care coverage to many more than before. Our nation faces a significant challenge of caring for a growing patient population with limited resources, and as was mentioned, the challenge even with the number of providers available to meet the needs. We must ensure that the Medicaid program has the flexibility through these waivers to address these needs. As has been said, these waivers are negotiated between the state and CMS, but especially as we have seen in California, the agreement affects many more stakeholders once it is in place. Recognizing this fact, the ACA included an important provision to encourage broader stakeholder input during the waiver process. Now there is a formalized process for the broader coalition of stakeholders to contribute, and I think that range of perspectives has created better and more effective waiver programs. I think both sides of the aisle agree that this aspect of transparency is so vitally important. Ms. Iritani, can you talk more about how public comments have helped and will help to increase transparency throughout the Medicaid waiver process?
Certainly. Yes, we raised concerns with the lack of transparency in the approval process dating back to the early 2000s. In a report in 2002, we talked to a number of different states and advocacy groups and others about demonstrations that had been recently approved that significantly affected beneficiaries, and found that there were great concerns about groups even being able to see a copy of the proposal prior to the approval. In some cases, I think that there were FOIAs involved to try to get transparency over what was being approved. And the Patient Protection Affordable Care Act did require a public input process at the federal level, which we think greatly enhances transparency of what is being proposed and provides for input to the process prior to the approval. So we would agree that that's an important reform.
And so you have seen progress since this has been initiated?
We have not looked at public
You're not
input
measuring it.
since the law was passed.
Okay.
But we
Do you intend to?
We agree that it has increased transparency.
How are states responding to these kind of comments?
We have not looked at that. And in terms of how are states responding to the proposals?
The proposals and the process of the whole transparency issues.
We have not looked at that, at how states are responding to the process.
Do you see this as part of your overall objective, or is it up to somebody else to do this piece of it?
Oh, well, we would be happy to look at that. The work that we've been requested to do in recent years has focused on budget neutrality and the new costs that were approved in the demonstrations.
Which is a lot to be assigned to and be
Yes.
grappling with in light, especially in my view, of the total, I won't say overwhelm, but increase in volume. I mean, that's really been a sea change. You want to explain, I have a few more seconds left, and what are some of the issues that you have faced, or how has this process been received?
The public input process?
Right.
Well, you know, as I say, we haven't looked at it since it was implemented, but we did look at the regulations that implemented it and agree that it was responsive to our recommendations that they provide for a federal input process.
So we're on the path, but it's early yet to interpret any results. Is that what I'm hearing you say?
I would say that it's an important step to improving transparency, yes.
Right, but we need to keep checking back and do you have the means by which you can accomplish some of these goals?
I'd be happy to work with the subcommittee on work looking at that.
Thank you for the time. There you go, Ben.
Chair thanks, gentlelady. Now recognize the gentleman from Pennsylvania, Dr. Murphy, 5 minutes for questions.
Thank you. I'm here. Good morning. It's good to be with you, and thank you for your work. I want to ask about one a demonstration project that was authorized in the Affordable Care Act that relates to the Institution for Mental Disease Exclusion, IMD exclusions for emergency care for people with psychiatric conditions. As part of comprehensive mental health reform, this committee will be deciding and considering modifications in these IMD exclusions to increase access to timely and cost-effective short-term psychiatric care as opposed to boarding in emergency rooms. And that is what I understand is the demonstration report that was worked on for that study. Can you tell the committee, if you're aware of this, what CMS has learned from current Medicaid emergency psychiatric demonstrations, and which created an exception for this IMD exclusion for adult Medicaid enrollees who've been determined to have emergency psychiatric conditions? Are you aware of any of this?
I am not. That demonstration was not within the scope of our work.
Is that something that you'd be able to look at? Because it is one of the demonstration programs. Is it totally excluded from your work to review that?
I believe that is a separately authorized, not under the 1115.
Well, let me ask a little bit more about this, because I value your input on this. But I understand the final evaluation, though, for the demonstration will be completed in the fall of 2016, so it's still ongoing. Do you have any advice or suggestions you can make to this committee to help us shape how we review these to make the most effective policies, for example, on these IMD exclusions? Is that something you'd be able to advise us on?
Well, I need to see more specific information, but yes, we'd be happy to talk to the subcommittee about new work on this
Thank you.
issue.
And also, would CMS support extending the current Medicaid emergency psychiatric demonstration till at least the final evaluation is available? Because we have an initial 2013 report, but we don't have, the rest is going to take some more time. And what we see is in the states involved, because we limit hospitals to have less than 17 beds, because it seems to only cover people who are suicide or those most severe cases, it still leaves us in a position where we are having problems putting these pieces together. We want to provide effective care for people. We want to do it in the most cost-effective way, but also recognizing you can do cost care without providing anything. We don't want to do that. We want to make sure we're providing effective services. And I believe that the Government Accountability Office has a record of really helping us look at and analyze those numbers. So I'd be grateful if that's something you can help us with. It's a key issue that this committee has got to deal with, because otherwise what happens with Medicaid for people ages 22 to 64 is they have nowhere to go. We had a recent hearing in the subcommittee where Senator Creed Deeds of Virginia was here. His case was one where he took his son to a hospital in Virginia, and the hospital said, we don't have any beds. And what happens so often is these men and women they may be boarded in an emergency room. They may be tied to a bed if they're assaultive. They may be given chemical sedatives, and they said there's just no room. And it is this Medicaid rule, which was based upon closing down those old institutions and hopefully having some other support services. We close the institutions down. We don't have enough hospitals because Medicaid has said you can't have them. And so in his case, he took his son home. His son took a knife and tried to kill his father, slashed him up pretty bad. His father escaped. Luckily, some driver picked him up as he was running out, but unfortunately his son killed himself. Now, I know that these aren't the cost-effective measures that GAO looks at, but it's something we all care deeply about. Is how do you put a number on that? How does he put a number on his son's life? And given the 40,000 suicides that occurred in this country last year, given the 43,000 drug overdose deaths that occurred in this country last year, those numbers are staggering, and they're getting worse every year. So we have to affect this. So your input, GAO's input, I would value greatly as we help address this to look at these numbers and costs and saying this is not acceptable
to this committee, it's not acceptable to this country. Quite frankly, it's not acceptable to the human race that we have done this, and the outcomes too often are death. I yield back.
Chair thanks the gentleman, and now recognize the gentleman from Oregon, Mr. Schrader. 5 minutes for questions.
Thank you, Mr. Chairman. Ms. Aratani, what is the rate of Medicaid reimbursement compared to private insurance coverage in general?
That's going to vary by service and state. Oftentimes, for fee-for-service, Medicaid rates may be lower, but again, it's going to vary.
They're always lower and significantly lower. I know in my state it's very dramatic. It's hard to get providers sometimes to see Medicaid patients unless they're a mix, because the rate is almost half, and sometimes not even covering the cost of these services. What is the rate of, is there a general rate of medical inflation that GAO uses to estimate savings when they're evaluating these different programs? And
We applied HHS's own criteria for how states should develop spending limits. And that criteria is that states should project what Medicaid will cost, which becomes the basis for the spending limit, based on the lower of either the state's historical spending trends in recent years or the president's budget's projections of Medicaid growth for the nation as used in the president's budget.
But when you say it's always more than the general rate of inflation, medical inflation is generally higher than regular inflation.
I cannot.
Well, the answer is yes. I mean, there's not a state in this country that doesn't budget for a higher rate of medical inflation for its healthcare programs compared to services and supplies. My state was easily 3, 4, sometimes 5 times historically prior to the advent of the ACA, which has now driven down healthcare expenditure increases dramatically. A little shocked that GAO doesn't have this information, actually. Isn't it correct that for these designated state health programs that these have been around a long time, not a recent figment of this
approvals? Some of the original approvals of the demonstrations we reported on in our recent report had been approved years ago.
So
yes.
prior to this administration?
Yes.
Okay, good, good. And isn't it accurate that CMS, with your latest report, has agreed with most all of your recommendations and is inclined to supposedly work to improve them?
Yes. We had 3 recommendations around issuing criteria about how to further Medicaid demonstration objectives, around improving the documentation about how they apply that criteria, and about making sure that they consistently provided assurances in the approvals that there wouldn't be duplication of funding. Good. And they agreed with 2 of those, the documentation-related recommendations. They partially agreed with the first one, indicating that they had general criteria that they used. They did not commit to issuing criteria.
Well, and I guess I have a concern as I listen to your testimony and some of the queries by some of my colleagues. I'm a little concerned where you're encouraging CMS to actually get into the micromanagement of the state waivers. And I think that's a big concern. Criteria defining how states have to have certain procedures in place and all. Shouldn't we be outcome based? Shouldn't we be outcome focused? Don't we just want to see more coverage for more people, better health care outcomes? I mean, that's something that my colleagues and I can evaluate. Some of my medical physician colleagues, they perhaps have a greater degree of understanding. But for those of us in the lay field, I feel more comfortable evaluating the outcomes, not defining criteria by which these states who are trying to give more flexibility to give better coverage to more people over the long haul. That really should be the goal. I am concerned that CMS may interpret, or my colleagues may interpret, your queries as to wanting to micromanage these states. And I think that's the wrong way to go. I think that's really the wrong way to go. Don't you feel that outcomes are the most important criteria by which we should judge success in these programs?
I would agree that improved outcomes for federal spending is important. Healthcare costs are increasing, and we are concerned about the long-term sustainability of the Medicaid program. Our work has really focused on the spending aspect and the approvals of the spending. Certainly, I think that the goal of many demonstrations is to improve outcomes. But given the longstanding policy that they not raise federal costs, I think that's been the focus of our work, and that's where we think reforms are needed, because it's the long-term sustainability of the program that could be at risk.
I yield back. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognizes Dr. Burgess, 5 minutes for questions.
Thank you, Mr. Chairman. And just picking up on Representative Schrader's questions and the observation of outcomes versus micromanagement at CMS. And we as physicians are always held to this standard. We're going to pay for performance, and we're going to pay for value, not volume. Do you ever provide or look to a pay for performance standard for CMS when evaluating these programs?
We have not looked at that, but I know some of the demonstrations, I think, are evaluating that.
Well, it just seems like, again, we're all too willing to burden every physician across the land with new requirements, and yet we never ask the same of the bureaucracy, and really we ought to be for patients before we're for the bureaucracy. I do have a question. It may require an answer in writing, but let me pose it to you, and I will get it to you in writing because the answer may be longer than time will permit us to do here. But we've heard several times this morning that applying for one of these waivers, the 1115 waiver, can be burdensome, time-consuming. I know it happened in Texas. Mr. Bouchon referenced Indiana. Can you discuss ways in which the Department of Health and Human Services could streamline the approval process for the 1115 waiver?
Our work is really focused on the approval processes for the spending, and we have examined the approval times, which vary greatly among demonstrations. There are many factors that we've been told contribute to that.
Well, but I would like, if you would, and I apologize for interrupting but time is short, I would like your evaluation of why that variability exists. Again, we in healthcare, if we had that degree, or when we have that degree of variability, people are always willing to ask questions and point fingers at us. I would just like that same standard applied to CMS when issuing these waivers. Just very briefly, according to your report, the Department of Health and Human Services actually did not have specific criteria for these 1115 waivers. Now they do, but do you have a sense of what the criteria was before you issued your report?
They did not have any written criteria regarding how they made these approvals.
So it was flip a coin, draw straws, just how I feel that morning when I get up? No criteria at all?
Officials told us that it wasn't within the Secretary's interest to specify criteria.
Well, and then that brings up the point, because we've kind of watched what's happening down in Florida, and now that expansion of Medicaid is the #1 issue for the Obama administration going forward. This is the sine qua non of President Obama's legacy, is the expansion of Medicaid. It really does seem like that power is being brought to bear on a state that had a functional 1115 waiver for their low-income pool. Now it needs to be re-upped, but the pressure's coming that you've got to do something different that you haven't been doing before. Am I wrong to get that impression?
We would agree that transparency is needed in the approvals, in the approval process, and the criteria that's used, and our concerns have been longstanding based on reviews of many, many states' demonstrations.
Well, the good news for both of us is that this is the most transparent administration in the history of the country, so we, I guess, can take some degree of solace on that. The question of budget neutrality, and you brought that up a couple of times when approaching and approving these 1115 waivers, but GAO has had some concerns about this, actually going back into 2008, into the Bush administration. Center for Medicare and Medicaid Services has consistently asserted that policies are adequate and applied consistently, but really, to me, they are not. Could you share with us, and again, this may be an answer in writing because of time, but can you share with us ways that you think Congress could use to remedy this issue?
Yes, we believe congressional intervention would be helpful in this case. As I mentioned in my statement, our concerns about the approvals are longstanding. I think we have a report dating back to the mid-90s on the budget neutrality process raising concerns, and the Secretary has consistently disagreed with our recommendations to reform the criteria and process around approving the spending limits. So we have elevated the recommendations that we made to the Secretary about improving the process as a matter for congressional consideration.
Well, I thank the gentlelady for her testimony. I will submit those questions in writing. And Mr. Chairman, if I could, if you would yield to me for a unanimous consent request.
Gentleman may proceed.
Chairman, I have request unanimous consent to enter into the record a letter by my Attorney General in Texas, Ken Paxton, several others Attorneys General about the issue of the 1115 waivers, and I would ask for its inclusion in the record.
I reserve the right to object.
All right.
Again, I make the unanimous consent request that
He's
this
made
letter
the
be-
unanimous consent
I'd
request.
just
Do you
like to make
object?
a short statement, and then I'll remove
All
it.
right, the chair recognizes the gentlelady.
I just want to point out that part of that letter is inaccurate when it comes to the state of Florida and what transpired there, since the state of Florida was on notice since 2011 that it was unlikely that the low-income pool was likely to survive in its current form. And due to the fact that CMS and the state of Florida have in fact negotiated the matter, the state did not expand Medicaid, and the LIP does survive. This simply points to the fact that we've all got to work harder to make sure we're working on behalf of the taxpayers. GAO has been critical of not allowing federal waivers to spend extra money, and we've all got to be mindful of that. And if we take this tack that states have coverage, but they get these uncompensated care pools that don't have much accountability and transparency, that's not going to serve Medicaid patients very well, and the congressional intent to be strict and wise with taxpayer dollars. But at this time, I'll remove my objection.
Thank you. Without objection, letters entered into the record. Chair thanks the gentleman. Now recognizes the gentlelady, Ms. Castor, 5 minutes for her questions.
Yeah, I just have a quick question. The transparency regulations also require states to be more transparent, have hearings, have comment periods, but this is so difficult for folks who rely on Medicaid services back home. Because remember, Medicaid, really, it serves primarily children, the disabled population, elderly in nursing homes, especially for states that haven't expanded Medicaid. They've transitioned now, many states, to Medicaid managed care. And what I hear from folks at home is it is very difficult to have any real idea on where accountability lies, where they can go for recourse when they have an issue. For example, I had a woman in my office from Florida last week who has a severely autistic son. And she, under managed care, they've changed providers, and she hasn't had the ability to weigh in with policymakers on how care is going to be delivered to her son and other families. Here's another example. Doctors are extremely frustrated. I had a pediatric dentist in my office just a few weeks ago from Florida. He does the Lord's work in taking care of hundreds and hundreds of children across my state and their dental health care needs. And that's smart because you take care of dental health needs and you save the state and federal government money down the road. But they do not have any recourse into inquiring at the state level. what's happening with changes in demonstration projects and waivers. Can the GAO take a closer look at how states can do a better job? Have you done that, and what recommendations do you have to help these families, patients, and providers have more access to what's happening?
We haven't looked at the public input process since the early 2000s. We haven't been asked to, but we'd be happy to work with your staff regarding re-examining how things are working. As I said earlier, we thought that the federal input process that was provided for in recent legislation was a very good step, because before it was really just up to the states to get input, and that was often difficult for beneficiaries and others to weigh in.
I'll look forward to doing that with you. Thank you. I'll yield back my time.
Chair thanks gentlelady. Now recognize gentlelady from North Carolina, Ms. Elmers. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Ms. Iritani, for being here today with us. You know, based on your testimony and some of the questions and discussion today, it looks like CMS is creating overlap and duplication through its funding of state health programs. Under Section 1115, basically CMS is authorizing federal matching funds for state programs despite the fact that other federal agencies already provide funding for these causes. It would seem that we are duplicating billions of dollars. With that, could you discuss the steps that CMS is taking to ensure that the funding of these state-based programs does not result in overlap of duplication of federal funding?
We found really mixed results in what CMS was doing in the documentation around providing for assurances that the new spending that they were approving for the demonstrations would not duplicate other federal funding sources. There were some states where the documentation would actually provide for specific laying out of the different funding streams and requirements on how to offset the Medicaid funds with other federal funding streams. But in many cases, there wasn't such a requirement, which raised concerns to us.
In your report, it lists that 150 state programs for which CMS authorized federal Medicaid funding, while many of the programs based on their name appear to be worthwhile and for good causes. I'd like you to expand on how some of these programs promote Medicaid's objectives. And I want to give you 3 examples, and if you can just help us understand how this fits into the Medicaid space and should be approved for funding. How about licensing fees in Oregon?
Yes, we, you know, the point of our report is that we could not tell how that and other examples of the state programs that were approved actually related to Medicaid objectives.
So the other 2, now one one example I have, healthcare workforce retaining in New York. Now, certainly we need a good, strong health, workforce. Do you feel that fits into the Medicaid space as well?
We felt like many of the approvals that CMS had approved were on their face only tangentially related to Medicaid, and without any criteria about how the Secretary was making these decisions, we could not make an assessment.
Yeah. And then the last one I have is Fishermen's Partnership in Massachusetts. I'm like you. I'm just going to assume that you're going to say that that also fits into that same characterization.
Yes.
And lastly, I just want to ask a little bit about the broad authority of the 1115 statute. What are the outer boundaries that the Secretary has to approve Medicaid funding?
The 1115 authority is very broad and gives the Secretary discretion to waive certain Medicaid requirements in 1902A of the Social Security Act and approve new costs that are not otherwise eligible for Medicaid that, in the Secretary's judgment, are likely to promote Medicaid objectives. It's a broad authority.
So, and I think that probably is about the best characterization. It's quite a broad authority and gives quite an incredible amount of discretion. Well, thank you, Ms. Aratani. That's all I have, Mr. Chairman. Thank you. I yield back the remainder of my time.
Chair, thanks, gentlelady. Now recognize the gentleman from California, Mr. Cardenas, for 5 minutes for questions.
Thank you very much, Mr. Chairman. Appreciate this opportunity to go through these issues, Ms. Iratani. I hear of some of the concerns about budget neutrality, but I also understand that CMS has taken new steps to make their approach to budget neutrality more transparent and enhance understanding between CMS and the states. On October 5th, 2012, they released the Section 1115 template for states to use in order to clarify the requirements and simplify the application process. This template includes instructions and an accompanying budget worksheet that provides guidance on some of the most commonly used data elements for demonstrating budget neutrality. That being the case, is this a step in the right direction?
We would still maintain that much more is needed. That template that was issued provides guidance, but it's a voluntary. States do not need to use it, and CMS's written policy is quite outdated in terms of their typical practices for what they review and how they review things, and what data they require, and we believe that more reforms to those things are needed to ensure that there's more consistency in approvals.
Is it the case that prior to October 2012, the HHS had not issued anything like this?
As far as I know, yes.
Okay. So hopefully what that means is HHS recognizes that they need to have a better transparency and understanding and with everybody involved when it comes to their responsibilities and giving the states this flexibility, correct?
The Secretary has consistently disagreed with our recommendations that any sort of reforms to their process for reviewing are needed. And this dates back to the early 2000s when we first made recommendations to the Secretary around transparency. And we have multiple reports. There's a list attached to my testimony statement dating back to the mid-90s. And regarding our recommendations to the Secretary on transparency and accountability in the review and approval of spending limits, the Secretary has consistently disagreed that anything is needed.
Mm-hmm. Can you give us an example of one of those statements of disagreement based on your reports?
We have recommended that the Secretary issue criteria for how they review and approve the spending limits, and provide for better documentation regarding the basis for approvals of the spending limits and make that publicly available, as well as ensure that states are required to use appropriate methods for projecting Medicaid costs. Mm-hmm. And the Secretary has indicated that generally has disagreed with that any of those reforms are needed to the process. And that's why we have elevated our recommendations to the Congress as a matter for consideration to require the Secretary to do these things.
So those objections on behalf of the Secretary, based on those recommendations, was there any indication that it's something that they could do or just something that they disagree with? Because one of the problems that I've experienced being a policymaker for 18 plus years now is that it's one thing to make recommendations to a department or a government entity, and it's another thing for them to admit that if we had the resources, maybe we would do so, but we don't have the people power or the resources to actually implement those recommendations. Is there any indication whatsoever that resources are an issue as well on behalf of the department?
That has not been something that the Secretary has said. I think that their response has generally been that they are, they use consistent criteria and that they have treated states consistently, and that they believe that their current policy and practices do not need reform.
And overall, are you aware of any of states overall, on balance, not appreciating that flexibility, or that they do, in fact, want to continue that flexibility relationship with HHS and the individual states?
We have not, discussed with states the spending limit process particularly, but, given that the Secretary has authority to approve new costs not otherwise matchable and to approve spending limits that may be much higher than what, the state has justified, I would think states would actually embrace it. But our concern, again, is with the long-term fiscal sustainability of Medicaid and, how this affects the federal budget and federal taxpayers.
Thank you. I yield back to balance.
Sure, thanks, gentlemen. Now recognize the gentleman from Indiana, Dr. Bouchon, 5 minutes for question.
Thank you, Mr. Chairman. As a physician who's taken care of Medicaid patients for a couple of decades, this hearing is very valuable to me today. I want to point out that Medicaid is a critical program that we need to have, that our citizens need, but clearly we need more oversight. I do want to point out that, in my view, though, the traditional Medicaid is not good insurance coverage, and that's been shown already with the Medicaid expansion under the Affordable Care Act, where emergency room visits are actually up, not down, across the country. That's not my opinion, that's factual. And when I was a practicing physician, when I first came to Evansville, Indiana, there wasn't a single fellowship-trained OB-GYN that would take a Medicaid patient in my community. Now, that's changed some now that physicians have been essentially kind of forced into being employed by hospitals, especially in that area. And one of the surrounding states, surrounding Indiana, some of the anesthesiologists at my hospital didn't even bother to bill Medicaid for the care that they provided for those patients because the state ran out of money before the end of the year, and the reimbursement was so low it didn't even make sense to spend the administrative cost to bill them. So that said, some of the things you pointed out about where waivers are using appears to be given with no specific approval criteria. It's not in a rule, it's not in a statute, it's not in a law, and that has resulted in some money, billions of dollars being spent on non-Medicaid, really type spending that should be associated with that program. Further spending money that could be used for direct patient care has been pointed out by a number of members. So it seems to me that specifically legislation likely is needed. Would you agree or disagree with that?
We would agree that congressional intervention and oversight would be important to addressing these issues.
Yeah, and some states, as you probably know, have been operating under an 1115 waiver for decades. And some have suggested that as part of that process, Congress create a process where longstanding core elements of an 1115 waiver can effectively be grandfathered into the state's state plan amendment, which directs the operation of the program. Do you have any thoughts on that?
I do not have a comment. Our work has not looked at that kind of process.
Because it seems to me, I mean, if you have a program in your state that's working, and you've been getting waivers for decades, sometimes that during the, how we utilize the Medicaid program, we should just change it so that we don't have to continue to ask for these waivers. And, Healthy Indiana Plan 2.0, which was put into place after the original Healthy Indiana Plan was successful and has data to prove so. We had to fight for 2 years to get a waiver for something that's been shown to be effective. And also that the patients, over 90% approve of, and it actually saved probably 2 or 3% in our Medicaid budget in our state, and has allowed us to cover individuals with low-income individuals with a program that's not traditional Medicaid that actually reimburses providers at a level that they can accept. And so it actually is increasing access to patient care. I don't have a specific question other than those comments. I think that many of the questions I've asked, was going to ask have been answered. But just to say that, it really is hard to believe that after decades of recommendations from you all, that we're still wasting money in it seems in the Medicaid program. At the same time, where the reimbursement rates to providers is limiting access to care, to direct care for patients, and it seems to me, Mr. Chairman, that we're going to need legislative action. I yield back.
Chair, thanks, gentlemen. Now recognize the gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you, Mr. Chairman. Thank you for being here this morning. Despite the fact that CBO has indicated that under Obamacare, ACA's Medicaid expansion would, on balance, reduce incentives to work, and that a work requirement component for the able-bodied would increase available resources for Americans, to date, CMS has refused to approve work requirements as a part of Republican state demonstration waivers. Is there anything in the Section 1115 statute that would prevent CMS from approving work-related requirements?
We have not encountered that kind of proposal in the work that we've done, so I can't comment on the Secretary's authority in that case. But as I mentioned, the 1115 does provide the Secretary with quite broad authority.
So a cursory view, it would not be unreasonable for some of us to think that that broad authority would not preclude a work component requirement for the able-bodied.
As I said, we haven't encountered that kind of requirement in our work, so I can't comment on that.
I appreciate that. Since 1115 demonstration programs are intended to be experimental or pilot projects to test new ways of providing services, it's my understanding that each demonstration is to be evaluated. Has GAO reviewed the evaluations of demonstration programs, and if so, what have those evaluations taught about ways to reform the Medicaid program to provide better access and services to beneficiaries?
We have not been asked to look at that component of the demonstrations, but you're correct. These demonstrations are supposed to be evaluations and have an evaluation component. We did in the mid-90s in a report discuss the major impact that some of these demonstrations had on beneficiaries and other things, and looked at the progress reports that states were submitting to CMS, and also the planning for the evaluations, and found both were lacking. We made recommendations to the Secretary to improve both those things, and we have not since been asked to look at that.
Did they ever get back to you and say that they had implemented your recommendations that you made back in the mid-90s?
They agreed with the recommendations at the time, and then at some point, and this is years ago, I think they said they were no longer, reform was no longer needed.
Thank you. I know that as a part of waiver renewals, some states send CMS evaluation reports that may be posted on the CMS website. Do you know if CMS also conducts its own analysis?
We haven't looked at evaluation for years, so I can't comment on that.
All right. So you don't know if they're doing their own evaluations as well,
Well,
as what the state says?
What I do know from our work from the mid-2000s is that the demonstration terms are typically 5 years, but they can be less, and that CMS required at the time that the state plan an evaluation, and that they also, because they wanted to understand how the demonstrations were working and if information was being collected to actually do the evaluation, they required progress reports. But that's again where we found that the progress reports weren't always complete or being turned in timely, etc. So we feel like the evaluation component of the demonstration authority is an important one.
And of course, if CMS doesn't do their own evaluation of those demonstrations, it's kind of hard for them to really assess it if they're just relying on the states. I do appreciate you being here today, appreciate your testimony. Thank you so much for answering my questions, and Mr. Chairman, I yield back.
Chair, thanks, gentlemen. Now I recognize the Vice Chairman of the subcommittee, Mr. Guthrie, 5 minutes for questions.
Thank you very much. Thank you, Mr. Chairman, for yielding, and thank you for being here today and answering the questions. I want to talk about the budget neutrality policy. In your testimony, you indicated that one of the problems with CMS's implementation of its budget neutrality is that it allowed some states to include hypothetical costs. Can you define hypothetical costs as CMS has implemented and some examples of that?
Sure. There are two main components to basically the budget neutrality process and projecting the cost of Medicaid without the demonstration, which becomes the basis for the spending limit that would be allowed. One is a spending base, which is by the policy supposed to be based on actual historical expenditures for Medicaid in the state for a recent year. The other is the growth rates that project costs over the course of the demonstration. CMS has, since we first started looking at this issue in the mid-90s, allowed hypothetical costs, that is, in the spending base. So that is, they would allow states to project or use baselines based on not what they were actually covering, historical costs in their Medicaid program, but what they could potentially cover, for example, populations, hypothetical populations that they could cover under the flexibility under the Medicaid program, but were not covering, or payment rates. In more recent demonstrations, we found that CMS has allowed states to assume that they would be paying providers more than they were actually paying as part of their baseline for developing the spending limits.
So, and then, so is there anything to stop CMS from applying budget neutrality to one state, but not another state? Could they favor one state over another in the way they apply budget neutrality? Is there anything to stop them from doing that? And could this could cost billions by allowing hypothetical costs?
There are tens of billions of dollars being approved in these demonstrations, and a lack of transparency over the basis.
So they could favor one state over. There's nothing to prevent them from favoring one state over another. In that, they make the decision on state-by-state basis, I guess, and so they could.
I think oversight
needs to be okay. And then, GAOs. What would GAOs say to the charge that some have made the budget neutrality would prevent CMS from making important investment in state innovations?
Could you repeat the question?
So what would GAO say to the charge that some have made that budget neutrality prevents CMS from making important investments in some state innovations?
Well, the whole concept of budget neutrality is that states would figure out how to innovate and get flexibility from traditional Medicaid rules, but within their current constraints of what they've been spending for Medicaid. I think it's one thing to innovate when you're getting a lot more money to do so. It's another thing to innovate with flexibility around Medicaid's traditional requirements, but creating efficiencies in doing so and not raising costs for the program. And we think that's a very important concept, again, getting back to the long-term sustainability of the program.
But if one state's receiving X amount of dollars and they want to innovate, and they say you can innovate within that X amount of dollars, but if one state's receiving X amount of dollars and CMS says you get X amount of dollars plus hypothetical cost dollars, that could be applied on a state-by-state and not consistent, correct? So that eventually, essentially a state's getting more money to innovate. Am I reading that wrong or understanding that wrong?
Different states develop their spending limits different ways.
Well, thank you. I yield back, Mr. Chairman.
Chair, thanks, gentlemen. And now I recognize the gentleman from Florida, Mr. Bilirakis, 5 minutes for questions.
Thank you, Mr. Chairman. Appreciate it very much. And thank you for your testimony. In Florida, we recently finished getting an 1115 waiver with CMS. I'm sure you're aware. It was a long, hard process that included a state lawsuit against the federal government over the process. Florida has had an uncompensated care fund, which we call the LIP, the Low Income Pool, for our Medicaid program for almost a decade now, which should have been a simple process, in my opinion, to renew that fund, turned into a long, drawn-out affair by CMS, who decided to change the rules this year. Ms. Saratani, when HHS reviews and issues 1115 waivers, do they follow precedent established with other approvals, or is every application reviewed from the beginning?
If I understand the question, is it when HHS approves a demonstration, does that set precedent for others?
Yeah, for others and maybe previous applications for that particular state as well. Or do we have to start from the beginning? First with others, yes.
We haven't looked at differences in, how HHS approves new approvals versus extensions versus amendments, which are all different ways that HHS can approve things. That said, I think HHS, with every new approval, does set precedents for other states to follow. And there are many demonstrations that have been operating for many years, right, as someone mentioned.
Okay. Next question. HHS provided GAO with 4 general criteria. You stated that. That state programs must meet to receive the funding through the 1115 Medicaid waiver. However, the criteria are so broad that they can be interpreted in many different ways. Question, is such activity fair to states and stakeholders, and does GAO think that the HHS needs to issue regulatory guidance explaining these criteria?
We believe that more specific criteria, written criteria, are needed, and otherwise we believe that many questions about the basis for the decisions, as well as consistency of approvals, will continue to rise.
And I understand that the GAO was not even aware of these criteria. Is that correct?
Yes, correct.
Okay. Next question. GAO's work suggests that there is likely significant duplicative federal funding streams for state programs under waivers and other HHS programs. Do we know if HHS reviews for duplicative payments prior to or after approval? If not, the mechanism for HHS to prevent duplication, or at a minimum recoup duplicated funding, say billions of dollars for us?
We have not looked at how HHS monitors spending post-approval. We have looked at, what protections they provided in the terms of the demonstrations regarding preventing duplication, and found variation, and in some cases no assurances that the new spending for Medicaid would not duplicate other purposes.
Okay, next question. In my estimation, there is a clear lack of uniformity in CMS decision-making. I think it's pretty obvious from the testimony. Are there criteria that could explain why 2 states of a similar nature get uncompensated care pools approved for different lengths of time? And I know my friend Mr. Guthrie touched on this as well.
There are no criteria that would explain that, and that's part of why we're recommending that there be criteria. We feel like that's important for transparency and for a common understanding of why the Secretary is making certain approvals.
Thank you. One last question, if you don't mind. I've got a few more seconds. Have you ever encountered an instance when CMS would force a state to take an action that their governor and the legislature did not want to take in order to renew the 1115 waiver that was already in existence?
I'm not aware of that kind of circumstance, but we typically have looked really at the approvals. at the federal level.
All right, very good. I yield back. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now I recognize the gentleman from Missouri, Mr. DeLong, 5 minutes for questions.
Thank you, Mr. Chairman. Doctor, if we're facing serious budgetary challenges, wouldn't it be better for us to prioritize medical care for patients in Medicaid rather than some of the questionable projects being approved for federal spending in these 1115 waivers?
We would agree that many of the approved new costs in the recent demonstrations, that documentation was lacking as to how they related to Medicaid purposes. And, you know, our position has always been that Medicaid funds should be for ideally covered Medicaid services for Medicaid beneficiaries. You know, the demonstrations give authority to the Secretary to approve new costs for purposes of the demonstration, but they should be furthering Medicaid objectives, and that's why we think there needs to be more articulation on the Secretary's part of how she makes those decisions.
So you do agree that it'd be better to prioritize medical care for patients in Medicaid?
We would agree that Medicaid objectives should be the driving, is within the 1115, should be the driving factor for decisions, and it's just not clear how the Secretary defines those.
Okay. One of my big concerns about the growth of Medicaid program is there's the temptation to just cover more people. Everybody always wants to be philanthropic and, oh, let's cover more people without ensuring that the access is timely and meaningful for these patients that they're wanting to cover. But from what I understand of GAO's work, CMS say they define low-income patients as 250% of the federal poverty level. 250%, that's a fairly decent income in several districts around the country. And you think it's appropriate for CMS to approve spending Medicaid dollars on what would be middle-class incomes in a lot of areas?
One of the things we were looking for when we looked at what new costs that CMS was approving was whether or not those costs, for example, with the state programs and the low-income pools, were for providers that were serving low-income and Medicaid individuals, and found that some of the programs were for the general public and or not clearly linked to low-income populations, and we find that questionable.
But do you think, so you do find it questionable, the 250% mark?
We have, you know, states have great flexibility to define how they define low income. You know, the poverty level, levels that they cover under Medicaid vary greatly. So we feel like it's the Secretary's decision and discretion to define what she considers to be Medicaid purposes.
Which apparently is 250%.
It's, you know, within the authority of the Secretary to define how she defines low income and Medicaid.
Okay, I've got about a minute left here. So 1115 waivers are supposed to further Medicaid's objectives. Medicaid's a program which exists to provide access to medical care for vulnerable populations. So how does the administration get away with justifying some of these spending approvals?
The Secretary, in the response to our draft report, said that they had general criteria that we discussed earlier that they applied, and that they apply criteria consistently and treat states consistently. And that's the general response they had.
Okay. Thank you, Dr. Tani. And I yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentlelady from Indiana, Ms. Brooks, 5 minutes for questions.
Thank you, Mr. Chairman. I think you've already heard a little bit about the Healthy Indiana Plan. And at the beginning of 2015, Indiana was fortunate enough to have its demonstration approved by CMS. Now, the Healthy Indiana Plan 2.0, or what we call HIP 2.0, as we call it, is really an extension, an expansion, and some changes made to a very successful Healthy Indiana Plan. Started under Governor Daniels and then expanded and changed slightly under Governor Pence. It provides 350,000 uninsured Hoosiers with access to health care services. But what was very different about it, and I thought what was really so effective, started under the first HIP plan, was that individuals would pay small contributions, and this was a huge sticking point for CMS, ranging from $1 up to $27 a month based on their income level into power accounts. And power accounts stand for personal wellness and responsibility, responsible accounts. Now, this allows people to create a sense of personal responsibility for their own health care, put in $1 a month up to $27, and it took our state years, as the gentleman from my delegation has already stated, to get this type of plan approved. And it has had demonstrated tremendous success. So after it was finally approved, after our governor had to speak with the president personally about a very successful program in order to get it approved, Governor Pence sent our entire delegation a letter suggesting that the manner, he was celebrating the success of finally getting it approved, but also the delay in the approval process itself caused so much stress and anxiety among the Hoosiers who were on the plan that it's just completely unnecessary. And it was all about the timing, quite frankly, that I'm complaining about, and the manner in which the approval process took place. It's my understanding CMS has no set time period. Is that right, Ms. Iritani, about how to approve these requests for waivers? Is that true, that there is no time period in which the CMS director has to provide their decision on these requests, even of programs that are already in place?
I believe there's a time limit on extensions, but otherwise, no.
And so if any changes or improvements want to be made to really, speaking of the fact that you haven't evaluated or delved into the evaluations, as I understand, of our HIP program were outstanding. And that's why we chose to expand it for more Hoosiers and to change it to try to bring more Hoosiers into the program. The Upton-Hatch Making Medicaid Work blueprint included a proposal for a waiver clock. Would it make sense for a time frame to be implemented related to these Section 1115 waivers? And what kind of guidance should we have from you and from your study of the waiver process? What should Congress be taking into consideration as we try and tighten the time frame for these waivers for CMS to approve or to not approve these programs? Because they keep our state legislators in knots, those who are receiving.
Yeah, other than the 2013 report that I mentioned, where we looked at the variation in the timeframes and the factors that CMS told us contributed, including the complexity and comprehensiveness of the proposals, we haven't addressed timeframes in our work. We've really focused on the spending limits and new spending approved. That's been the scope of our work.
Do you agree, though, that the time frame issue is a significant issue for the states?
Some of the factors that that CMS said contributed to the more lengthy approval times included things like how comprehensive the proposal was. You know, some states operate their entire Medicaid demonstrations or Medicaid programs under a demonstration, so it effectively changes the entire program. It could be the states need to go back to the legislatures to get new legislation, and when they do, then there may be changes to the proposal that CMS has to review. It's very complicated to sort out why things take so long.
Thank you. Thank you for your work. I yield back.
Chair, thanks, gentlelady. Now I recognize the gentleman from New York, Mr. Collins. 5 minutes for question.
Thank you, Mr. Chairman, and thank you, Ms. Iritani. Is that correct?
Yes.
Yes.
Thank you.
For all your testimony, this is an area, I guess you could say, of overall concern when, as I understand it, the CBO recently issued their 215 long-term budget outlook, and in that said that in just a little more than a decade, our entitlement spending will consume, along with service on our debt, 100% of the inflow of monies into the U.S. government. If we look back 40 some odd years ago, it was $1.03. Today, these same programs are $2.03, and it's truly a major concern when it would hit $3.03. So something's going to have to give, and unfortunately in Congress all too long, the kick the can mindset of let me get past my next election is very much alive. And so here we have the CBO, which should be send a chilling effect to all of us that we've got to make some changes, and Medicaid is certainly a major contributor on the expense side of those entitlement programs. So my question really comes down to maybe asking you, do you have some suggestions for Congress? And as we're looking at these 1115 waivers, and in particular, I think your testimony indicated that some of these waivers really didn't go to the core proposition of what Medicaid is there for, but very tangentially associated with it, and it's even hard to get your arms around how some of these waivers are benefiting or could benefit us in the long term. Do you have any idea how many dollars are in that kind of bucket? And do you have any recommendations for anything Congress could do, however small that might be, to at least try to stem some of these expenses that we wouldn't have to have?
Yes, we share your concerns about the impact of these waivers. The spending trends of the funds that are governed by the terms of demonstrations are rising significantly. In 2011, we reported that about a fifth of Medicaid spending was governed by the terms and conditions of demonstrations. In 2013, we said it was about a quarter. In our most recent report, it's almost a third of Medicaid spending, the over $500 billion program. So we believe that given that the Secretary has disagreed with the need for reforms, that the Congress should consider requiring the Secretary to take certain steps to reform the process.
Well, I think we agree, and I certainly appreciate you being very forthright in that observation, and I really do thank you for your testimony. With that, Mr. Chairman, I yield back.
Chair, thanks. The gentleman now recognize the Vice Chair of the full committee, Ms. Blackburn. 5 minutes for questions.
Thank you, Mr. Chairman, and in the spirit of the College World Series, I'm here to bat cleanup, and I'm going to be fast. So we can move to our second panel. I'm going to pick right up where Mr. Collins left off. $344 billion program, and 1/3 of that is now in the 1115 waivers, correct?
Well, total spending, including federal and state, is actually over $500 billion.
So in total, over $500 billion with that, once they do the state match to the federal.
Yeah, $304 billion federal, correct.
All right. And one of the things that we are looking at with this, if I've got my notes right, I want to be sure that we've got you right for the record, is that you've got a lot of gray area here on how decisions are being made, that meeting the objectives has become very subjective, and that you have not gone in, if I understood your response to Mr. Bilirakis, you said that you all have not looked at spending post-approval or looked at the outcomes. You've just looked at that process of pushing the money forward. Am I correct on that?
Yes,
Okay.
we've only looked at the approvals of the spending limits and the basis for them.
Okay,
And
but not the outcomes?
Correct.
Or the delivery? All right, and so that is something that we definitely need to circle back and do some oversight on. Let me go back to Ms. Castor's question. Did I understand you to say you've looked and reviewed the federal end, but you have not looked at the public input process on the 1115 waivers?
Not since the mid-2000s.
Okay.
That's when we raised concerns about the lack of a federal public input process that was then addressed in the recent health reform legislation.
Okay, and I think that gets to part of Ms. Brooks' question also. There have been mixed results, and you have mentioned that. You've got states as diverse as what Indiana has done. You've got Arizona, which was one of your first 1115s. I'm from Tennessee. We have a very mixed result history, if you will, with the 1115 waiver process. So it concerns me that you all have not done a deep dive, if you will, on looking at the outcomes, reviewing these results, looking at that public input process, going through that. Because if I'm following what you're saying, a conclusion would be that when you set up a demonstration project and there are 4 criteria that have to be met for this to move forward, and with the subjective nature of the decision-making process, a state can meet 1 of 4 criteria and be approved and be considered a success. Is that correct?
I believe so. That's the...
So they could have a failing grade, if you will. If you're on a grading scale of 100 and you meet 1 of 4 criteria, you're at 25% effectiveness. But CMS would consider that a success.
The criteria, the first time we saw them again was just in CMS's response to our report. They were not issued or in any written guidance, and we have not since circled back to CMS to see how they apply it. But the way that they stated it in their response was that basically one of these criteria is basically what we apply.
And then setting the spending limits, they pretty much make it up as they go along and are subjective in that approach, if I understood you correct in your response to Mr. Bouchon.
There's a lack of transparency, definitely.
Yes. Okay.
How they're set.
With that, Mr. Chairman, I yield back, and I thank you, Madam Director, for your time today.
Thank you.
Chair, thanks to gentlelady, and now recognize the ranking member of the full committee, Mr. Pallone, to bat cleanup. 5 minutes for questions.
Thank you, Mr. Chairman, and I apologize that I wasn't able to be here until now, and you know, I may be repeating some things that already have been said or have been asked, and so, you know, forgive me for that. I just wanted to say that after close to 20 years of recommendations for more transparency into the Medicaid waiver process, the Affordable Care Act included a bipartisan provision to improve the transparency of Medicaid waivers in line with long-standing recommendations from GAO. Today, because of this provision, the public has meaningful opportunities to provide input into the waiver process at both the state and federal level, and waivers are now evaluated on a periodic basis, and states submit reports on implementation, and this was a huge step in the right direction, in my opinion. I'm further encouraged by CMS's concurrence with GAO recommendations, specifically in their April 2015 report for better ongoing and transparent documentation of how states spend Medicaid dollars. This is a recommendation that prior administrations had refused to correct, and I continue to believe it's the right thing to do to ensure dollars are following our Medicaid beneficiaries. But let me ask a couple questions if I can. In reviewing the GAO recommendations over the last 20 years, it appears as though your recommendations have remained the same until only recently. Isn't it true that the majority of these recommendations were not acted upon until Obama administration initiatives and the Affordable Care Act, which placed many of your recommendations into action?
We've made many, over a dozen recommendations over the course of this time, and only a couple have been implemented, including the public input process that you mentioned that was implemented in 2012.
Okay. And of course, that was under under President Obama in 2012. Based on the GAO reports, it appears that GAO recommendations on the budget neutrality accounting principles have remained unchanged since as far back as the 1990s. So is it true to say that this fundamental disagreement between HHS and GAO has remained the same, regardless of which political party has controlled the presidency?
Yes.
Okay. And then the last thing I wanted to ask, and to follow up on that, isn't it true that GAO went so far as to issue a letter to HHS from GAO's chief legal counsel regarding budget neutrality issues in the prior administration? I mean under the last President Bush.
It is true in 2007, our legal counsel did issue a letter to the secretary at the time raising concerns with 2 states' approvals, yes.
And have you had to take such action under the current administration, under the Obama administration?
We have not.
Okay. All right, thanks a lot. Again, Mr. Chairman, I'm not going to take up too much time because I came in the end here, but thank you for the opportunity.
Yeah. Chair, thanks, gentlemen. That concludes the questions of members present. We will have follow-up questions in writing. I know some of the members not here have questions. We'll send those to you in writing. We ask that you please respond promptly. Thank you very much for your testimony this morning. Now, as our staff sets up the table for the second panel, we'll take a 3-minute recess. The committee stands in recess. Okay, the time for recess having expired, we'll reconvene the subcommittee, and I'll introduce our second panel in the order of their presentations. We're delighted to have today the Honorable Haley Barbour, former governor of Mississippi and founding partner of BGR Group, with us this morning. Mr. Matt Salo, Executive Director, National Association of Medicaid Directors, and Ms. Joan Alker, Executive Director, Georgetown University Center for Children and Families. Thank you each for coming today. Your written testimony will be made a part of the record. You'll each be given 5 minutes to summarize your testimony. There's a series of lights on the table. So when the yellow light goes on, that's 1 minute left, and red light means you could wrap up at your convenience. And at this point, Chair recognizes Governor Barbour. 5 minutes for your summary.
Thank you, Mr. Chairman. When I last testified before the committee, I was actually a governor. I want to make plain that I'm not governor anymore. I don't speak for the governors or the Republican governors or even the governor of Mississippi. This is what I think. You know, states are trying to juggle demands of increasing health care costs while trying to balance their budget. Most of our states actually literally balance the budget every year. And this is a huge part of it. In 2014, the federal government spent $300 billion on Medicaid, $344 this year, as I understand it, but also the states spend a ton of money on Medicaid. Medicaid, in the next 10 years, that budget for the federal government is going to go to $575 billion. And when you put in what the states do, it'll be about $1 trillion. So this is a big burden on the states' budgets and on the federal budget. I think we all ought to remember that about 2/3 of all federal spending is mandated for entitlements or payments on the national debt. And that percentage is growing. Any discussion of Medicaid and our health care programs must include some mention of our ability to pay the bills that we're accumulating. Because what we do today affects future generations' ability to pay the debt that we burden them with, and affects their chance to experience the American dream that we have been blessed to experience. Since January of 2009, the federal debt has gone up 73%, and that can't continue. We got to provide quality health care for the truly needy in a cost-effective manner. And one way to help do that is give each state the flexibility to run its Medicaid program in the manner that best meets the needs of its population. I personally believe Congress should give states authority to adjust their programs without any CMS waiver, as long as it's within the law. But at a minimum, the waiver process needs to be improved. For instance, should states be able to ask some non-disabled adults if they'd prefer to pay a small copay if it better ensured they're being able to see a doctor? Not really a problem in Mississippi. 83% of our doctors take new Medicaid patients. But y'all have already cited a story in California where somebody got on Medicaid and couldn't see a doctor. In New Jersey, about 38% of doctors take new Medicaid patients. Wouldn't our patients be better off if they really could have a way to get care, even if it meant paying voluntarily on their own choice, a small copay? I believe copays really help make the system work. When people miss an appointment, there ought to be a copay because they've cost somebody else an appointment. They've cost another Medicaid person or some other patient. I believe states should be allowed to do work requirements or job training and retraining for able-bodied adults who are on Medicaid. CMS is standing in the way of a lot of state innovation by not approving common-sense waivers and taking long periods of time to approve the ones they do. It's been talked about already about the opacity, that this is not transparent, inconsistent standards, and the concerns about favoritism or about using waivers as a way to coerce states. CMS has reached an agreement principle with Florida on the Florida LIP program. The bottom line, though, is Massachusetts got theirs last year. in October, about the same time that Florida was applying. The Medicaid program in Florida asked CMS in the fall, and just now there is an agreement in principle. By the way, that agreement in principle cuts the contribution to the program by more than half in the first year and by 2/3 in the second year for what Florida will receive. We do need transparency so that the states understand the process, how to get things approved, and I would say to you, not only should there not be different rules for different states, I believe when a state like Indiana institutes a program and it works well, and we test whether it's working well and find that the results are good, it ought to be an easier process for another state to adopt that. Things that work, we ought to encourage. If Oregon's got something that works and we think it fits Mississippi, it ought to be easier to get a waiver for that than starting at scratch. So I would encourage the committee to go to block grants, but I would certainly encourage you to adopt a waiver clock, to adopt some rules about transparency, and remember, a successful program under a 115 also ought to be allowed to become permanent if we see that the results are such. Why should they have to go back every couple of years? Sorry I ran 14 seconds over. Pretty good with my accent.
You're pretty good. Thank you. Chair recognizes Mr. Salo, 5 minutes for your summary.
All right. Thank you, Mr. Chairman, Ranking Member Green, members of the committee. I represent the 56 state and territorial Medicaid agency directors. We've talked a lot about how big Medicaid is. I don't want to belabor that, but I do want to underscore how complex it is. And I think a lot of people don't fully appreciate that. We cover, yes, a lot of children, a lot of pregnant women, a lot of low-income families, but we also cover a lot of individuals with disabilities, intellectual, developmental, physical, as well as a lot of people who need long-term services and supports. In fact, we are the largest payer in the healthcare system of long-term care, of mental health, of HIV/AIDS care, et cetera. It is a complex, it is a difficult program. Our members are responsible and accountable for the program. They are striving to provide the best possible health care to the citizens we serve and also be wise stewards of the taxpayer dollar. They are also hard at work, actively driving program reform. Now, lest people think that driving program reform means that the underlying program is broken, I would say unequivocally no. And in fact, I would posit to you the challenge is the broader U.S. healthcare system, which is failing us. Take a look at this. Healthcare cost inflation has exceeded CPI for decades. Healthcare is now 18% of the nation's GDP. We have suboptimal outcomes to show for that. We also have profound political division about what the future is of healthcare is. But I think an important piece here is that we have also had decades of either proactive or passive policies in this country of either ignoring or actively shifting responsibility for many of these difficult populations directly to Medicaid. And that is why we are the largest payer for the most complex, the most expensive, and the most difficult to serve populations in this country. So what are we doing about it? We are actively trying to reform a healthcare system, a fee-for-service system that does not serve these populations well. As Dennis Smith once said, fee-for-service, FFS, ought to stand for fend for self, because that is what we are requiring of the sickest, the frailest, and the most complex patients. But this is hard. And part of the challenge is that the statute at 50 does not allow us to do what we need to do. So we rely on waivers. And we have been relying on waivers for decades to drive program improvement. In Arizona in 1982, in a number of states in the mid-90s, with the private option in Arkansas, and other states who have done the expansion recently. With Indiana, as we've heard, and with many other states that are doing DSRIP or other types of programs. We have a long history of success with this, and accountability does exist. There are evaluations, there is reporting, and even though GAO may not particularly like it, there are budget neutrality calculations. And finally, there is significant public input. Which is not to say we think the system is working perfectly. We think there are a number of changes that can and should be made. We have been fairly vocal in what these kinds of things should be. Our shorthand for this is the system should be more of an HOV program. And the HOV for us stands for healthy patients, outcomes, and value to the taxpayer and value to the healthcare system. These principles ought to drive what we are doing and how we are able to do it. We've got a number of ideas that I'm more than happy to talk about, ways that we can get there. Some are incremental, some are bigger. Some of them will require congressional input. One of those, as Governor Barbour referenced, is sort of a pathway to permanency, and we can talk more about how that might play out. But I do also think we do need more timely approvals and renewals. We can talk about what that might look like, but I think a big challenge, in all honesty, is capacity at CMS to be able to do the reviews in a timely manner. And I think we need to keep in mind that there needs to be a balance between transparency and flexibility. We do need transparency, but we do need the flexibility to innovate. And I think we need to be careful about prescribed, definitive checklists of what can or what cannot be done, because that sets a ceiling for what can be innovated, not a floor. And I think we need to be very mindful about how do we spread the innovation once we know that it works. So let me close on this and just say that I think a lot of states spend a lot of time, energy, resources on chasing paper trails, on trying to prove to everyone's satisfaction budget neutrality or other types of process requirements. Too much time arguing about the cost per unit of widgets that do not contribute to the overall value of the healthcare experience, and that we need to start investing more in state capacity to actually drive the changes that we seek. And I'm happy to talk about some solutions for that as well. Thank you.
Chair, thanks, gentlemen. Now recognizes Ms. Alker, 5 minutes for opening statement.
Thank you so much, Chairman Pitts, Ranking Member Green, and members of the committee. I really appreciate the opportunity to be here today because I've been studying Medicaid waiver policy for many, many years now. And while I find it fascinating, many think it's sort of boring. So I'm thrilled that you are interested in this issue. I'd also like to commend the GAO for their long history of excellent work on this issue. It's been 20 years now that GAO has been writing reports that I've been reading, raising questions and concerns about Medicaid waiver policy. And these issues have arisen regardless of which party, Democrats or Republicans, have controlled the executive branch. And today I'm going to focus on two areas of concern raised by the GAO: the need for transparency and robust public input, as well as the question of budget neutrality. And the good news from my perspective is that after 20 years of scrutiny by GAO and others on these issues, I think we're finally making significant progress on both of these issues. But there is still some work that needs to be done. So first, on the issue of transparency, I do believe it is vitally important to have a very strong and robust process for public comment at both the state and the federal levels. This is an idea that has long bipartisan support. Senators Grassley and Baucus worked on this on the Senate side, and language was included, as you heard, in the Affordable Care Act, and that was implemented through regulations in 2012 by the Obama administration. So these changes have led to dramatic improvements in the public comment process, but I'd like to make a few suggestions to the committee for you to consider that might lead to greater transparency and better public input in the waiver process. The first suggestion is that current public input requirements only apply to new Section 1115 applications or renewals, but not to amendments to existing Section 1115 waivers. Since so many states already have a Section 1115 waivers, there are many important changes that occur through the amendment process. So I believe it would be a valuable amendment to the law to ensure that amendments were also subject to the public input requirements. Second, while significant progress has been made with respect to having waiver applications and approvals online at Medicaid.gov, there is more work to be done here. Many important documents, such as operational protocols, quarterly and annual reports, and other significant deliverables often required in terms and conditions that come with Section 1115 waivers, are not always publicly available on Medicaid.gov. And I would urge you to urge CMS to make sure those are publicly available as soon as possible. And then finally, I'll just say, I think this suggestion came up from a number of committee members earlier in the day. I think it would be terrific to have GAO do a report that looks specifically at how the public comment process is working, particularly at the state level. Now, let's turn to budget neutrality. Again, GAO has found that administrations of both parties have approved budget neutrality Section 1115 agreements, which, in GAO's judgment, were not adequately supported by sound documentation and adequate methodology. So budget neutrality is very complex, and of course, when the Secretary makes decisions about what state programs to include or how to assess budget neutrality, the Secretary is responding to state requests. CMS is not just making these things up. CMS is always responding to a state's request. And so by definition, every state's request is different. But I think in the past few months, we have seen some encouraging signs from the Obama administration with respect to how Secretary Burwell plans to approach budget neutrality agreements going forward. In particular, on April 14, 2015, CMS Director Vicki Wachino sent a letter to the state of Florida indicating 3 principles by which they would approach their review of Florida's low-income pool, which has been discussed here today. In addition to sending this letter to Florida, press reports indicated that CMS also made calls to 8 other states that currently have some kind of uncompensated care pool through a Section 1115 waiver agreement. These are both states that have done Medicaid expansion and states that have not done Medicaid expansion, and they've shared these same principles to signal their intent to apply these criteria across states. Even more recently, I understand CMS has started including specific ways in which expenditures authority, and I believe this is part of the Oregon Health Plan extension that was just approved, where they tie in the Secretary's judgment how those expenditure authorities are linked to the objectives of these programs. So both of these actions that I've just described, something that I've never seen before in the last 20 years, so that's encouraging to me, but I do think we'll need to continue to monitor this issue very closely. So thank you very much for the opportunity to testify.
Chair thanks the gentlelady. Thanks all of you for your testimony. We'll begin questioning now. I'll recognize myself 5 minutes for that purpose. Governor Barbour, yesterday 10 Republican attorneys general wrote Chairman Upton expressing their concern over CMS's coercion to try and get Florida to expand Medicaid under the Affordable Care Act. As you know well, the Supreme Court's NFIB versus Sebelius ruling made such an expansion voluntary for states. Do you believe the administration's actions here are legally problematic?
I do. These attorneys general are there because of something we've been talking about, the lack of transparency, the lack of real hard rules, so you don't, you got so much discretion, and certainly these states see it as coercion because they did not choose to expand Medicaid under the ACA. So that appears to be the case. We'll see what the court decides. But I will say this: it's for a lot of states, this idea of 1115 waivers would affect them tremendously, and they think they're not getting their waivers treated the same. And there is some evidence that if you look at the low-income pool program in Massachusetts and the one in Florida, both have been in effect for a long time. Yet Massachusetts was approved last year well before the time needed so that they could plan for their budget. Florida got really hung up, ended up going to a special session because they didn't get approved the same time as Massachusetts. So I think that's why these people are thinking that.
Thank you, Governor, and I'll let each of the others also respond to this. It is my understanding that CMS has no set period of time for reviewing and responding to requests for 1115 waiver, but CMS has to review and respond to other waivers for managed care and home and community-based services within a certain time frame. So my question is, would it make sense for a time frame to be implemented related to the Section 1115 waivers?
Yes, sir.
Mr. Salo?
I think conceptually that makes sense, because I do think the challenge is that you're correct. There is a lot of frustration that sometimes approvals or renewals can take a very long time to get. I would caution, though, that in practice, I would worry that a definitive clock might just, if we don't have the rules, if we don't have the structure in place to ensure that CMS has the capacity to look through these, that a short clock might just get them to no faster,
Ms. Alker.
which is not what we want. We want to be able to get to yes faster, and I think we need to focus on that, but certainly to speed the process up.
Ms. Alker.
So I'd say a few things. First of all, I think many of the recent substantial waiver approvals like Arkansas and Iowa happened pretty darn quickly. And we have to balance the committee's interest in the need for transparency and public input with this desire to have quick approvals. And I think we have to find kind of the sweet spot where you allow sufficient time for public input and comment with adequate time for CMS to review this very complex policy and make decisions. And I'll just give one example. The GAO in, I believe, 2007 did a report criticizing approvals at that time by the Bush administration of the Florida waiver and the Vermont waivers, and underscored the lack of public input. And I believe the world record approval for Section 1115 went from Governor Bush to President Bush, and it was 8 business days. So that wasn't great because clearly a lot of that was sort of wired out of the public eye. So again, I think we need to balance the need for timely and efficient government action with the need for appropriate public comment and oversight by yourselves as well as the public.
Mr. Salo, you mentioned in your testimony the length of waiver process. You indicate it took nearly a year on average from the time a waiver application is submitted until it's approved. My understanding is that there are often months of negotiations that occur even before the application is submitted. Can you please discuss a little bit more the difficulty that such a lengthy process, nearly a quarter of a governor's term, nearly half of a term of a member of the House, like myself, creates for states and for Medicaid program beneficiaries?
Sure, and I think, you know, I do want to be careful to acknowledge and respect the dialogue that has to go on between the states and their federal partners on this. That dialogue is important, and you know, and there is a certain amount of deference that we should allow the administration, any administration, as the payers of half this program. But as you pointed out, when you drag out these negotiations, oftentimes what you will have is amendments that need to follow and other things that are related get backed up, and that can bring the effective, you know, functioning of good government to a slow crawl, and that's not going to be in the best interests of the patients. That's not going to be in the best interests of the healthcare system.
Chair, thanks, gentlemen, and now recognize the ranking member, Mr. Green, 5 minutes for questions.
Thank you, Mr. Chairman. Ms. Ackerd, my home state of Texas is next in line for renewal of their waiver, and I want to be clear, I'm proud of what my state's accomplished through the delivery system reform efforts that have dramatically improved the quality of care for the Medicaid beneficiaries, and look forward to working with CMS in Texas to start the process. But I also want to make sure, there's a former state legislator, I think it's almost medical malpractice not to expand Medicaid for the states based purely on politics, is what we're doing. And in Texas, I know every hospital executive I know has asked the legislature to expand it, just like they have in other states, because people are not being served. And but that's, again, a state's decision by the Supreme Court. And I want to correct the record here, because there's a lot of misinformation flying around about Texas, just like Florida. Isn't it true that some undeniable similarities are both of our states have so-called uncompensated care pools, but that part of their respective Medicaid waivers and that Florida seems to have a tough time with? Ms. Ackerd, isn't it true that no one state has the same type of so-called uncompensated care pool?
That's definitely true, and Texas's waiver, I would say, is a lot more complicated than Florida's.
Okay. And wasn't there a fact that the longer-term issues at play with the structure of Florida's pool?
Yes, in 2008, actually, GAO issued a report that criticized the budget neutrality assumptions underlying Florida's low-income pool.
Is it true that Florida actually would have been able to get more federal dollars from the expansion plan that was under consideration by the legislature?
That's definitely true, and of course, those matching dollars would come in at 100% match currently, as opposed to their regular match rate, which is about a 60-40, so they get a lot better return on investment by taking up the expansion dollars.
Ms. Acker, Governor Barber's written testimony is very critical. CMS not allowing cost sharing in Medicaid. However, in 2013, CMS issued a final rule that revised Medicaid's cost sharing policies. The rule increased in the maximum allowable cost sharing amounts that the states can impose on Medicare beneficiaries, including individuals below the property line without a waiver. Ms. Acker, would you say that the states have considerable flexibility to, whether we agree or not with it, not here today, implement cost sharing policies for Medicaid?
That's true, and I think one of the common misconceptions about Medicaid is that you have to get a waiver to do everything, and that's just not true. We see that time and time again. As you mentioned, states are allowed to impose nominal copays on the adult population, and they don't need a waiver to do so.
Okay. And again, Governor Barber's written testimony noted that Medicaid providers should be able to charge beneficiaries a fine if they miss their appointments without notifying their doctors. And I'm concerned that we're pushing ineffective policy we know don't work, because while CMS actually approved Arizona's request to impose a $3 missed provider fine back in 2011, the state ultimately let the authority expire because there was so little provider participation. Is that correct?
Yeah, I think that speaks to the issue that came up earlier, that we need really robust evaluations of waiver demonstrations that have happened in the past, some of which we already know that are simply not good policy.
One of the issues I know with Arizona findings, but also like Georgia's emergency room demonstration goes unnoticed. Do you think it might be worthwhile to explore how we can evaluate and make publicly available the results of these demonstrations, so we might learn what strategies work to actually improve care and lower cost?
Absolutely. I am certain, obviously, as a public policy professor, very much a fan of evidence and research-based to inform our public policy decisions. I would say a couple things about the evaluation process. I do believe, but it would be a great question to ask CMS, that they have commissioned an overall evaluation of some of these new Section 1115 waiver approvals, recent approvals, that's in process. It would be great to learn more about that, because one thing I've observed is that sometimes in the evaluation process, particularly at the state level, that if you have the state paying the evaluator, that the researchers may not always be objective. So we need to ensure that we have independent evaluations to assess these policy choices going forward.
Mr. Salo, in balancing transparency and flexibility, you know that you fear strict guidelines for waiver approval might quickly become obsolete as our medical system advances. Would you agree that a set of broad principles should be, such as those put forth by the administration, is in fact the best balance to achieve these program goals?
In short, I would say yes. I think it is more important to have broad guidelines than clearly delineated checklists, because let's face it, what is approvable today would not have been conceived of or approvable 15 years ago. Yeah. And it is, in all likelihood, the innovations that are going to be driving real healthcare system improvement 10 years from now, many of which we probably haven't thought of today. So we're going to need the ability to think about things very different. This is an iterative process. Innovation is a dynamic and fluid process.
Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentleman from Indiana, Dr. Bouchon. 5 minutes for questions.
Thank you, Mr. Chairman. I think, again, it just strikes me, the mere fact that we're talking about waivers shows you that maybe the program itself needs to be changed so we don't have to have so many waivers. Same thing's probably true in education with No Child Left Behind that needs to reauthorize in a different way. And we're giving waivers to states because of poor policy that needs to be changed by Congress, and it seems like this may be an area that needs to be addressed. The thing we're continuing to address today, and as a healthcare provider I can say, is coverage and not really delving into cost. And I think some of you in your testimony have pointed out that the rising cost of healthcare and the inflation in healthcare is something that has to be addressed. I mean, you're not going to keep up with the cost of the system going up, like the governor pointed out, if you don't start to address that as an issue and not just address coverage. And if you're going to address coverage, you should address good coverage. And as I pointed out in the previous panel, I can tell you from experience that the Medicaid program, although critical, is financially strapped and doesn't necessarily guarantee access to physicians. Again, Governor Barber pointed out that in New Jersey, only 38% of physicians are taking new Medicaid patients. So that said, and the other thing someone mentioned earlier, that hospitals in certain states are asking for Medicaid expansion. I would too, because it means a huge financial gain for the hospitals, and the implication that that means that it's, you know, for altruism of covering people is not necessarily the case, and I just wanted to point that out. So with that, Mr. Salo, some have mentioned today that in recent years there's been greater transparency in the waiver process, such as through the adoption of requirements for public input, both the state and federal level. The ability for the public to provide input on proposed Section 1115 waivers is very important, of course, but it sounds like there's been still a lack of transparency and consistency regarding CMS's criteria for assessing 1115 demonstration applications. How does this lack of transparency affect state Medicaid programs, and what recommendations do you have for improving the demonstration, application, and approval process?
So I think a couple things probably need to be done. Again, several of us have referred to this pathway to permanency. Because a third, as we've heard from GAO, a third of all program spending is now incorporated into 1115 waiver. Pretty soon that's going to become the norm rather than a different example. And a lot of the things that we've been doing, Arizona has been doing this for 30 years. Tennessee and other states have been doing it for decades. There are certain things we just shouldn't need to get a waiver for anymore. You know, thoughtful managed care, coordinated care is one of them. Home and community-based alternatives to nursing home care is another example. If we can make the waiver process less necessary, if we can build some of those common sense developments into the underlying program, we can free up resources that can really be focused on real innovation. But I think it does still need to exist, because as we're seeing with states like Massachusetts and New York and Texas and others, where the delivery system incentive payments are being implemented, there are different things we need to try, and the system has to be accommodating to thinking outside of the box. And so I would say, let's make the 1115 waiver process less necessary, but still nimble and fluid enough to be able to accommodate the innovations that need to happen, not just today, but tomorrow.
Governor Barber, you have some comment on that?
Yeah, Doctor, I agree with that. That's very in line with what I said earlier. I would think for many things there shouldn't be any necessity for coming and seeking a waiver, in particular something that has already been proven to work well in other states. But one of the things that strikes me is we ought to base this on results. And yet GAO's witness here told us that CMS doesn't even test the results, that they don't look at the outcomes. And that's news to me. I hope it's really that's not quite accurate. But certainly that ought to be part of the test. Did it achieve what you said it was going to achieve? And budget neutrality? Was it within the money? I testified, Mr. Chairman, here 4 years ago that if you would give us a block grant, we would take half the annual increase in Medicaid that our state would be entitled to, because I thought we could save way, way more than that. I think if you have a waiver and you don't meet budget neutrality, the state ought to have to pay it. You'll get very good programs if the state knows they're on the line. And most states, I believe, most states wouldn't prefer that, but if that was the difference, they would take it.
I yield back.
Chair, thank you, gentlemen. Now recognize the gentleman from Oregon, Mr. Schrader, 5 minutes for questions.
Thank you, Mr. Chairman. A couple of comments, I guess. The course of the hearing, I find it astonishing that some states, some governors find it a burden to take care of the most disadvantaged people in our society, that Medicaid is not something, especially when the federal government's kicking in 90% of the cost. I mean, I'm a little old budgeteer from Oregon, a small business person. I was going to pay 90% of the cost of something. I'm going to find 10% of the money to get it done, especially for this population. And who are these people? Who are these shiftless people on Medicaid? They're children. They're seniors. They're disabled people. 80% of the Medicaid population is that group. I don't consider that shiftless. 70% of the people that are able to actually work, that are on Medicaid, that little 20%, 70% of them are working. And they can't afford health care. I mean, Medicaid, 138% of poverty level, that's like what, $14,000, $15,000 a year? I challenge any of us to try and live on something like that. Afford health care? You can't do that. Oregon had a small demonstration project that at the time I thought was very good. Yeah, everyone should pay something for their health care. Oh, let's see, we sort of do that under the ACA that's being demagogued on a regular basis. Yeah, people that are lower income but can afford something, yeah, we make them pay on a graduated basis based on their income and their socioeconomic level. But somehow what we're hearing today, you know, we don't like that because it's Medicaid. Medicaid's tougher, though. We had this demonstration project in our state, and we found that those people that are on Medicaid, they have lots of issues. They have multiple risk factors, folks. It's not like you and I that just decide not to work. There may be a few of those, but most have multiple issues. And frankly, they're not going to pay $5. You know, and enlightened self-interest ought to dictate to every one of us, even if we don't care about children, seniors, disabled, or the people that have multiple risk factors, that if we don't take care of these folks, their diabetes costs are going to go into our health insurance premium. I mean, that's been proven. That's one of the predicates over health care reform. Whether you like the ACA or not, that's one of the predicates of why health care reform is so important, to get the costs aligned like they should. And there are some good projects out there, though I agree with the general sense of this panel that the whole waiver system, the whole Medicaid system itself seems to be antiquated. And we should update it to be, I believe, outcome and results-based. I agree with that 100%. That's the future, not micromanaging. Very concerned when I heard GAO talking about, well, we got to have more criteria here and a little more definition there and count more widgets that are being processed. That's not the goal. The goal is to have higher quality health care at, frankly, less cost. And the way to do that, and it's in the ACA, and like it or not, even without the ACA, it's coordinated care. Aligning things so you don't have the duplication that GAO talks about. Oregon has a great demonstration project that they're doing right now that I think is very accountable. It's pretty gutsy. Basically, they got a bunch of money from CMS to develop this coordinated care organizations for Medicaid patients. That means that there's primary care docs, specialists, dentists, mental health professionals coordinating the care for Medicaid patients so that they'll know what each other's doing. They'll have an accountability in there, and they're in return for this money, the goal was to keep, not only get better outcomes, but get better value, not just for the individual, but for the taxpayer. Limit healthcare inflation to 2% through the duration of it. And I would, you know, as a healthcare, as a budget guy, I helped run the budget back in Oregon back in the day. You know, healthcare costs for healthcare inflation 6, 7, 8, 9% annually. It was a big deal. We always budgeted more than annual inflation on a regular basis, which was anywhere from 1.5 to 2.5%. So Oregon's going to keep it at 2%. That's impossible. Well, the results so far are pretty amazing. We're under 2%, under 2% inflation because of the coordinated care system. Emergency visits, I don't know about other states, emergency visits are down 21% from a couple years ago. That's substantial. Complications from diabetes down 10% already. This is the early stages of coordinated care. And chronic obstructive pulmonary diseases, hospital stays down 50%. That's what we're talking about. That should be the outcome-based type of information that every waiver should be judged by, and hopefully, ultimately, Medicaid reimbursement in general. I yield back.
Chair thanks, gentlemen. And now recognize the gentleman from Florida, Mr. Bilirakis, 5 minutes for questions.
Thank you very much, Mr. Chairman. I appreciate it, and good to see you, Governor.
I remember your dad, Connie.
Governor, some states have been operating under an 1115 waiver. You mentioned Arizona has been operating, I believe, since 1982, well, at least 30 years. Some have suggested Congress create a process where long-standing core elements of an 1115 waiver can be effectively grandfathered into the state's state plan amendment. Do you have any thoughts on that? And I know that the doctor had mentioned that too. I'm just following up on his question.
Yes, sir. I think that's absolutely a step in the right direction, that if you've got a demonstration project that has demonstrated that it works, that you're able to do it in a budget neutral or better way, and that the outcomes are what you were expecting and what you told was going to happen. If that's the case, at some point, it shouldn't be years and years and years later. At some point, you ought to just be able to make that permanent. And I think importantly to your sister states, if we are the laboratories of democracy, and if Florida's got something that really works, it ought to be easier for us to go adopt what Florida's doing, make some adjustments for us, but generally adopt what is proven to work in another state if we choose to, and not have to go through a big, long process that takes 337 days.
Sounds good. Thank you. Mr. Salo, one of the things that the many Republican governors have been interested in, they're interested in using 1115 waivers to test consumer-directed accounts with modest copay structures to encourage health literacy and individuals participating in their own health care. I agree with that. CMS has approved a few demonstration programs for this, but they have been stringent on the copays under the waiver program, I understand. How do you think that fact squares with the reality those consumers who make a few dollars more are suddenly expected to be shoppers on the exchanges? For example, at 133% of the federal poverty level, you could be on Medicaid with no copay, but at 134% of the federal poverty level, you would be on the exchange with no copays.
Yeah, I think the issue there is, and again, with deference to the administration's priorities, every administration is going to have priorities about what it wants to see done with its share of the Medicaid dollars. The current administration is not a huge fan of copays in the Medicaid program, but I think it is clear that a key point of what we need to do in the overall system to make healthcare better for people is that we have to have greater accountability, but for everyone. Yes, we need better consumer engagement, but we need to make sure that consumers have the tools to be able to do that effectively. And we need to also make sure that providers, primary care physicians or what have you, are accountable. We have to give them the tools to be able to do that. And ultimately, whether it's a health plan or whether it's the state, we have to have the tools to create an environment where all of those other pieces can succeed. You know, we don't want to just leave anyone out there with, you know, here's a ticket, good luck out there. We have to create, you know, it's not the Peter principle, it's the Peter Parker principle. With great power comes great responsibility. We've got a responsibility to be able to ensure that everybody within the system is going to succeed as we change it from a dysfunctional fee-for-service model to a better integrated, coordinated, managed care model. And that's going to involve consumer engagement, provider engagement, and state engagement as well.
Thank you. Last question, Governor, CBO has indicated that Obamacare's Medicaid expansion would on balance reduce incentives to work. Yet CMS has refused to approve work requirements as part of the Republican governor's state demonstration waivers. Are you aware of anything in Section 1115 that would prevent CMS from approving work-related requirements?
No, sir, I'm not. And clearly, having a planet where more people work in our economy. Today, only 48.5% of adult Americans have a full-time job. The labor participation rate's about 62.9%, the lowest since the 70s, before women had really come into the workforce in the numbers that they have in the last 40-something years. So, yeah, it's absolutely, now that we allow able-bodied, childless people to be on Medicaid, there's absolutely no reason we shouldn't look back at Bill Clinton's welfare reform law, which had work or retraining requirements.
Thank you very much. I yield back, Mr. Chairman.
Chair, thanks to the gentleman. I recognize gentlelady from Florida, Ms. Castor, 5 minutes for question.
Thank you, Mr. Chairman. Welcome, panel. I'd like to read from a Miami Herald article from about 6 months ago relating to Florida's Medicaid program. It says, in a sweeping decision, a judge says Florida systematically has shortchanged poor and disabled children by providing inadequate money for their health care. A federal judge Wednesday declared Florida's health care system for needy and disabled children to be in violation of several federal laws, handing a stunning victory to doctors and children's advocates who have fought for almost a decade to force the state to pay pediatricians enough money to ensure impoverished children can receive adequate care. In his 153-page ruling, U.S. Circuit Judge Alberto Jordan said lawmakers had for years set the state's Medicaid budget at an artificially low level, causing pediatricians and other specialists for children to opt out of the insurance program for the needy. In some areas of the state, parents had to travel long distances to see specialists. The low spending plans, which forced Medicaid providers for needy children to be paid far below what private insurers would spend and well below what doctors were paid in the Medicare program for a more powerful group, elders, amounted to rationing of care, the order said. And here are a few examples of what the judge found. Almost 80% of children enrolled in the Medicaid program are getting no dental services at all. By squeezing doctor payments, Florida health regulators left 1/3 of the state's children on Medicaid with no preventative medical care, despite the federal legal requirements. And this was true for both children paying fee-for-service or undermanaged care. In addition, the judge wrote, an unacceptable percentage of infants do not receive a single well child visit in the first 18 months of their lives. Florida health regulators sometimes switch needy children from one Medicaid provider to another without their parents' knowledge or consent. So these sweeping violations of federal law within a demonstration project, a Medicaid waiver, raise a lot of questions. And Governor, I heard you said, well, for Florida, for all states, if it's working, maybe we should keep it. But clearly here, if something is not working, they need to take a look at it. I think everyone would agree. So, Ms. Alker, you're fairly familiar with what's been happening in Florida. This is part of the reason that the low-income pool and these multi-billion-dollar, in Florida, these large uncompensated care pools have gotten a lot of attention over past years. A lack of transparency in the way the funds are distributed by the state. They're distributed not by, they don't follow beneficiaries. They go depending on, this pool of money goes to, depending on what counties have contributed. And they have raised serious questions about provider rates that have been cut over the years. What is to be done in a waiver situation when you have these uncompensated care pools and yet providers, doctors are not being paid adequately and children aren't getting the care they need?
So I think you raise a number of issues, and one of the really important questions is having, I think, strong oversight of Medicaid managed care. Particularly in Florida, there's been serious problems over the years with your managed care companies, and so part of what, if you build it in through the waiver process or through the new Medicaid managed care regs that CMS has just issued, that we really are going to need accountability for the taxpayer dollar with respect to these managed care companies. And I worry because I think that states have lost personnel. Their departments are often underfunded and they don't have the ability to oversee these managed care companies, ensure that we really are paying for care for very vulnerable children and others. And I guess with respect to the uncompensated care pool, I think it's also important to emphasize, as you mentioned earlier, Representative Castor, that the low-income pool in Florida doesn't cover a single person, and uncompensated care pools don't cover people. They came out of a time when particularly states had very high uninsured rates, but coverage is really a better way to approach the healthcare needs of citizens of your state and others, because the low-income pool doesn't protect families from bankruptcy. It doesn't ensure that folks get primary and preventive care. And to my mind, it's a smarter use of taxpayer dollars to make sure that people get coverage so they get the primary and preventive care they need so they don't get sicker and have to wind up taking uncompensated care from your state's hospitals.
Thank you. I yield back.
Chair, thanks, gentlelady. And now recognize gentleman from New York, Mr. Collins. 5 minutes for questions.
Thank you, Mr. Chairman. I want to thank all of the witnesses today for your testimony on what we know is a major concern for all of us, and I may direct this to Governor Barbour. As the CEO of Mississippi, I can just tell you, in my past life, I was the county executive of the largest upstate county in New York, where Medicaid actually was 115% of our budget, of our property taxes. So every single dollar that we collected in property taxes, every single dollar we collected was not enough to cover our Medicaid burden, because in New York, the counties pay a portion of the fee. That's not true in a lot of states. I don't know what it was in Mississippi, but in New York, our Medicaid costs are so outrageous that we pass a big chunk of it down to the 62 counties, to the point in Erie County, one of the poorest counties in the state of New York, home to Buffalo, it was 115% of our property tax levy. So we lived on only sales tax. Everything we did with highways and roads and supports of our culturals, our prisons, our holding center, 100% of everything we did outside of Medicaid was sales tax revenue, which is not a predictable source. So I'll get back to common sense. When common sense meets good government, I think that's a good day for all of us. And I want to talk about how nominal copays can make a big difference. I mean, we teach our kids, you raise 50 cents, I'll give you 50 cents. You want a new bike, you go raise this, I'll do that. A fundamental part of America is teaching people at a young age the value of a dollar. But in Medicaid, when there is no copay, and let me tell you another story. I mean, I can get pretty animated on this. We had in Erie County what we call the frequent flyers that use ambulances as a taxi service. They call 911, they climb in an ambulance, it takes them to the Erie County Medical Center, they get out and they start walking somewhere else. It was a free taxi cab. That's what it was. Because we don't have a copay. I suggested, why not a $50 copay? $50 to get into an ambulance and take you to the hospital. And we'd even have a way to potentially, for some of those, waive that. But that would be more expensive than a taxi cab. So if you're looking for a taxi ride, call a taxi, don't call an ambulance. And I was told, absolutely not, this isn't going to go that way. I chaired a commission, County Executives for Medicaid Reform, asking that we would have the ability at the county level to set up our own programs. And I was turned down on that one. So I just have a fundamental belief that having some level of pay, however little it is, invests a person in what it is they're getting, and that nothing in life should be free. So, do you have any comments, Governor?
We tried very hard to get CMS to agree to let us make co-payments enforceable, and we were not allowed to do that. Governor Daniels is quoted in some of the material. When they started the HIP program, everybody has to pay something. And I think the lady from Indiana said it starts at $1 a month. But I remember him saying, if you can afford a Big Mac, you can afford the copayment. And for people to for patients to be participating in their health care, making decisions because of copays, the decision may be generic versus brand name. The decision may be something else, but as an old Scots-Irish descendant, if it's a cash bar or a free bar, I know who drinks more. And if it costs you something, if you have to be part of it, you're going to be a better health care receiver because you're going to be cautious about that. And the copays don't have to be very large, as you say, or as Governor Daniels says, where they have a $1 copay. There's not anybody that can afford $1 a month. But anyway, I agree with you. My legislature, which had Democratic majorities in both the House and Senate when I was governor, they were for copays and enforceable copays. It's just common sense.
Well, and that's what I would say. It's common sense meets government. We should do something like this. In fact, to me, it should be part of the basic Medicaid program, because if we teach our 6-year-old kids the value of $1 and let's go out and do some work in the garage and clean up the house and then you earn and I'll pay the rest of your bicycle, we fundamentally know that anything that's free has less value than something you even pay a nominal part for. So certainly within the 1115 program, there should, in my opinion, definitely be a place for something for very small copays, and anyone who would debate otherwise, I think, is kind of leaving common sense at the door, unfortunately. Well, thank you again for your testimony. My time's expired. I yield back, Mr. Chairman.
Chair thanks the gentleman. Now recognize the gentleman from Massachusetts, Mr. Kennedy. 5 minutes for questions.
Thank you, Mr. Chairman. I want to thank the witnesses for coming today and for your testimony on an extraordinarily important topic. I apologize, I was bouncing around a little bit, and so I think I missed some comments earlier about the Massachusetts low-income pool. So, Ms. Alker, I was hoping you might be able to clarify. I know my colleague, Ms. Castor, brought up the Florida low-income pool, and I think there were some comparisons that were made earlier. In your assessment, ma'am, are there any noticeable differences between the way that the Massachusetts has set up its low-income pool and that of Florida?
I think there are. I'm not as familiar with Massachusetts. I think, though, when you look at the 9 states that CMS has identified with these kinds of compensated care pools, they're all different from each other. And as I mentioned before, one important step forward is that CMS earlier this year sent a letter to Florida about the principles they're going to use to apply to all states, excuse me, going forward as they consider their uncompensated care pool. And they're applying those principles both to states who have expanded Medicaid like Massachusetts and states who have not, like Florida.
Excuse me, right. So thank you for pointing out at least one important distinction. I also wanted to talk about, this has come up a couple of times today, but the work requirements, and with regard specifically to an issue that has come up also a couple of times today, mental health. One group that is particularly hit hard by unemployment are individuals that are suffering with mental illness. Committee had a hearing just a couple of days ago on improving our mental health care system in this country, and it's an issue that I know a lot of us care an awful lot about. In 2012, 17.8% of the seriously mentally ill were unemployed. This group of individuals could succeed at work if given the right opportunity the right employment supports, which is why Medicaid coverage is so important. Medicaid allows states to provide supportive employment services like skills assessments, assistance with job search and completing job applications, job development and placement, job training, negotiations with prospective employers. And Medicaid dollars can be leveraged to support state training programs for mental health providers who, in turn, serve low-income beneficiaries. In fact, Mississippi and Massachusetts have something in common. Both states are taking advantage of these types of opportunities. Mississippi is, I think, a great example of using Medicaid support to help state health programs. And Governor, your state goes so far as to provide services to help individuals start their own businesses, such as helping them with a business plan, finding potential financing, and ongoing guidance once the business has been launched. Massachusetts is doing some pretty outstanding work as well when it comes to treating mental illness and substance abuse. Flexibility in that waiver process allows Massachusetts to leverage state dollars to conduct community support programs, psychiatric day treatment, and acute treatment for children and adolescents. So, Ms. Alker, to start with you, do you agree that flexibility that states have today leverages Medicaid dollars to serve communities through the designated state health programs, and that it's a hallmark of the Medicaid program that should be protected?
Well, so let me say 2 things, and then if it's okay, I'd like to go back to the work requirement issue as well. So The kinds of programs that you're mentioning, I mean, this has been a hallmark of Section 1115 waivers for many decades now. This is not something new that the Obama administration has started doing. And also, it's not something which the Obama administration just simply says, we're going to give you money for. The states come to them with ideas, and, you know, I think we'd all agree if it's a good idea that supports the objectives of the Medicaid program, that then that's the kind of thing exactly that a Section 1115 waiver should test. And so I think, again, if we look at it from that long-term perspective, it's exactly what Mr. Salo is saying, is that over time there are more innovative ideas that emanate from states, and that is the hallmark of Section 1115 waivers. With respect to the work requirement question, because I think there's an intersection between the mental health issue and the work requirement that I'd like to point out. Work requirements strike me as a bad idea, both from a policy perspective, and they're possibly outside the purview of the Secretary's legal authority to approve, although I'm not a lawyer, so I'm going to leave that to others to comment on it. But I think they're a bad idea for the following reasons. I think we all share the same objective here, which is we'd like to see people work. We'd like to maximize employment. But it seems to me that imposing an arbitrary work requirement may in fact have the precise opposite effect, because you have folks perhaps who have a mental health condition that needs to be treated, and the health care, providing them with the health care, will allow them to work, and there will be a greater chance of them becoming employed. So I worry very much that a work requirement would have precisely the opposite effect of what is it intended.
Thank you, and I am unfortunately over time, so I yield back 5 seconds.
Chair, thanks, gentlemen. Now recognize the Vice Chair of the full committee, Ms. Blackburn, 5 minutes for questions.
Thank you, Mr. Chairman, and I want to thank each of you for your patience as we worked through the first panel, and then for staying with us. This makes for a long morning. We understand that, but as we look at the demonstration projects, we do want to come back in and review this, and maybe, as the director said earlier in the first panel, be able to put some guidelines in place and some more components for oversight and also for conduct. Put these into statute. So today is important for us. Mr. Salo, I want to come to you. In your testimony, you had said that simple accounting for Medicaid is extremely difficult, if not impossible. And we're talking about a program that's probably the world's largest health insurance program, and the spending's pretty much on autopilot at the federal level. A lot of problems with how this is playing out. And as a former state senator in Tennessee, and the experiment we had with TennCare, I fully understand the challenging nature of Medicaid and of working through these waivers in the 1115 program, but I want to give you a chance to explain this, because surely you are not suggesting that benefits cannot be quantified and that dollars cannot be tracked effectively, or that accountability is not needed. So would you like to respond to that?
I would love to, thank you. So I guess what I'm saying is I think what the GAO is searching for here is akin to, there's an old joke where there's a policeman walking down the street and he sees a guy on his hands and knees looking for something in the street under this street light. It's dark. And policeman comes over and says, what are you doing? He says, I'm looking for my keys. I lost my keys. So the policeman helps him. And he's there for like 5 or 10 minutes. He says, I can't find them. Are you sure you dropped them here? He says, oh, no, I dropped them down the block. Just the light's better over here. I think that's what's going on. I think the GAO is struggling for something that is really simple and really easy, that for the green eye shade approach of, well, I can put this in a checklist. This is simple, check, check, check. And I'm here to argue that Medicaid is much more complex than that. I am not saying it doesn't need accountability. It does. It has. And I'm not saying that we should not track the dollars, track the benefits. You should, and we do. What I'm saying is I think what the GAO is pushing for may not actually be good for the ultimate value in healthcare, health of the program itself. that as we start getting into very narrow
Well,
definitions
sir,
of what
I'm going
budget
to interrupt you
neutrality
right
is,
there. If the program is too expensive to afford, it's not good for anybody. And what we need to make certain is that we are looking at this from access to affordable health care, and to approach it from a viewpoint that, well, this is too challenging, the problem's too big to solve, so let's leave it on autopilot. That is not a responsible course of action, and that is something that we ought not to do. And it's exactly the reason we need to pull this back in and look at these 1115 waiver situation and look at the subjectivity with which these waivers are being given. Governor Barber, I want to come to you, talking about the subjective nature of this. And looking back through these uncompensated care pools, and you look at what happened with Massachusetts and Hawaii, and they're being given a much longer period of time for their extension on their pool as opposed to Florida. And what I don't like where this, you look at how this is playing out, and it seems like you've got CMS treating states differently if they're friendly to the administration as opposed to those that are not friendly to the administration. And that is troubling to me. I think it's troubling to a lot of people that are looking at Medicaid and Medicaid delivery.
Certainly, that's the contention of the Attorney General lawsuit, that because their states did not expand Medicaid, they are being coerced or they're being punished in doing this. GAO did not say different states get different treatment, but they did publish a list of who got their waivers redone, and it is pretty politically consistent. If you look down the list, they all voted for the same candidate for president. They got 2 senators in the same party. They all expanded Medicaid. Now, I can't look at anybody's heart and say that's why they made the decision, but that's why we need more transparency, not just in Democratic administrations, but in Republican administrations, of why did the decision get made?
Thank you. Mr. Chairman, I've got one other question for Governor Barber. I will submit it. It has to do with eligibility, and get an answer from him relative to that. I yield back.
Chair thanks the gentlelady. That concludes the questions of the members present. We will have follow-up questions. We'll send those to you in writing. We ask that you please respond promptly. I remind members that they have 10 business days to submit questions for the record. Members should submit their questions by the close of business on Wednesday, July the 8th. Another very important, interesting hearing, a critical program, needs attention of Congress. This has been very informative. We thank you for coming, and without objections, the subcommittee stands adjourned.